To have you all here once again. There we go. It is really fantastic to have everybody here again. So just a reminder that these weekly sessions, the Gastro Echo sessions hosted by the Gastro Foundation, are done in association with Project Echo, University of New Mexico, and held weekly on a Wednesday. Every week there's a different theme, and about once every 8 weeks, 6 to 8 weeks, we have a patient blood management session. The other weeks deal with things like liver disease, endoscopy, etc. That might be more focused on gastroenterologists, while the patient blood management sessions are really meant for the whole wide spectrum of medicine and anything to do with this particular field. So today, I'm very, very happy that I can introduce Dr. Evan Bowen, who is a hematopathologist trained at the University of the Free State in Bloemfontein, where he also completed his schooling. He didn't put it in his bio, but he went to Grey College, so I can say it on his behalf. I'm sure he's very proud of that. And Evan ended up with us today because he gave this particular talk on another forum, and Dr. Claire Barrett, who's a big contributor on our patient blood management platforms, suggested that we get Evan to speak to us. And I think the topic of today is very relevant. Lots of people have questions about the different kinds of oral irons, supplementation, treatment, where, what, how. And Evan is going to share his thoughts on that with us today. And I want to really encourage everybody to use the chat, ask your questions. Let's see what we can tackle. There are so many unanswered questions, surprisingly, still about iron and oral IV iron treatments, that it's a field rich to be mined in terms of research and thinking and creating new ideas about how to move what I consider to be the most common health problem in the world forward, except for those who are more interested in dental problems, for which I can do nothing other than encourage people to brush their teeth. So the next most common problem is iron deficiency. I just want to say a big thank you to everybody behind the screens as well that's putting these echo sessions together. Thank you, Cheryl Valentine, as well, that's been organizing this session today. And to the Project Echo team, we really appreciate it. I'm going to hand over to Evan immediately. I so look forward to his talk, and I also look forward to the question session at the end. So use that chat box. This is an opportunity, and let's make the best of it. Evan, over to you. Welcome.
Thank you so much, Prof. Lo. I should be sharing my slides, and we checked it earlier, so it should be working.
Yes, we can see it.
Perfect, great. I just want to close some things here. So I just want to give just to say I'm happy to be here, and I always tell the story. I'm very recently qualified, so I'm no means pretend to be an expert in this field, and I know there are many experts here, and many of you will probably see your names in the slideshow for the people that are involved. So I think of this talk as more of a way to open up a discussion around the topic and to try and enlighten ourselves and just improve ourselves in this very important sort of diagnosis. So this talk was originally given actually as a series of talks that we gave for an iron workshop that we presented here at the University of the Free State. So this one specifically looks at oral iron therapy. So you won't see too much about the physiology, which was given by one of my colleagues, Dr. van Marla, also excellent hematopathologist here. And you won't see too much about the testing, which was given by Dr. Haupt, and also IV iron, which was given by Dr. Claire Barrett. Won't feature too much in here. So we'll keep it to more or less oral iron, but I will be touching on many topics. And as for I'll say one more story before we really get started, is where I'm sitting right now is in a 2-kilometer radius from where I was born, where I went to school, where I went to undergraduate training and postgraduate training, and now where I'm working. So I may not have traveled very far, so let's see what the Free State has to offer in terms of oral iron therapy. Okay, let's go, yeah. There we go. So please let me know if my slides should be moving now, and if there's any issues, please stop me and I'll go back. So this is just more or less the outline of what I'm going to be talking about. So I'm going to touch a little bit on iron absorption, then talk about some of the oral iron formulations, a little bit about dosing, and then touch on patient education. I just wanted to start us off with a case that Dr. Haupt graciously gave to me. It's about one of our patients in our hemophilia clinic. It's a gentleman with hemophilia A, young gentleman, 20 years old. He's been having some episodes of epistaxis in the last few months, and I have some of his blood counts, over a few years here. And what we can see is, as I mentioned, I'm not going to touch too much on the iron testing. I'm going to make some assumptions, but this a ferritin of less than 30 generally is accepted as iron deficient. Here we can see his hemoglobin levels are more or less in normal ranges for a young man. So, and the MCV is also more or less in normal ranges. So here we could see an example of him being iron deficient, but without anemia. We can see that perhaps the ferritin went up a little bit throughout a couple of years. And then we can see transferrin saturation was quite low with a hemoglobin dropping. And then ferritin being very low at this stage with a low hemoglobin, and sort of the similar picture here later on. So we can see a sort of a progression from iron deficiency without anemia to full-blown iron deficiency anemia. And some of the things I just wanted us to think about as we go on through here, just a couple of questions, and there can be many more questions as we move along, is sort of at which points do we think oral iron would be appropriate, or where do we think IV iron would perhaps be more appropriate? And if we were going to give him oral iron, which product would you recommend? And let's say he were to come to you with complaints of side effects, what could you recommend? And there's also a few other things we can do around the oral iron therapy, which I hope we'll touch on. And we'll come to this case a bit later on as well in here, if I've taught you guys anything. So if we just briefly touch on the economy of iron in our bodies, the total body iron content is relatively small, 3 to 4 grams of iron, which is one of these nails here. I think it's actually this, perhaps the 2.5 inch or 3 inch nail. And there's no real physiological mechanism for excreting excess iron. The level of iron is controlled at the intake level. So this just goes to show, one of the reasons why is iron deficiency so common? And one of the reasons is that your body really does not want to take in excess iron because it can't get rid of it. Once you've got excess iron, it takes your body quite a long time to get rid of it. So it really needs to control the intake carefully. And that's why, the absorption is quite low. If we look at where iron is more or less in our bodies, we can see that there's a few areas we can look at. So as I mentioned, it's 3 to 4 grams overall. And your amount of loss to absorption is very low. 1 to 2 milligrams per day is lost, and that is more or less what we have to absorb. This is in normal physiological states. So only very low levels need to be absorbed. Oh, sorry, went the wrong way there. A large amount of your iron is recycled throughout your body. So your iron is used in your bone marrow, make red blood cells. This then goes to your reticular endothelial system, and this more or less 20 to 25 milligrams gets recycled throughout these systems in a daily basis. So not too much, so you don't lose any in these processes. It's a very efficient process. And then you get some that are stored as well, quite a large amount in your liver and then in other tissues as well. If we just take a brief look at how is iron absorbed in our bodies, well, you get iron in your food that you consume, and it comes generally in 2 flavors, either bound to heme as heme iron, which is found more in meats and fish. In the Free State, we don't consider fish a meat, so that's why I have to separate them here. And this is actually absorbed through a specific transporter, which we don't know too much about. It's one of the unknowns still of iron, that this is more readily absorbed through a specific transporter. Another flavor of iron that we absorb from our food is actually non-heme iron. This is generally initially or can be in the ferrous or ferric forms. If it's in the ferric forms, it first needs to be reduced to the ferrous form before being absorbed through this transporter here. And then it's in your epithelial cells. Now, this is where you can have your body can have some kind of decision about, should I absorb more iron or should I lose this iron? And this is done with the assistance of hepcidin. So you can see if hepcidin levels are high, iron absorption will be blocked, it will be trapped within these epithelial cells and sloughed off. So if you could think about it very basically, if you have too much iron, your hepcidin levels will be high and there'll be decreased absorption. If you have too little iron, your hepcidin should be low, you should have increased absorption. Now, there are many things that affect hepcidin, and I'm going to touch on a few points of hepcidin a bit later, but it's just important to keep this in mind, that higher levels of hepcidin reduce absorption of iron. You can give as much iron as you want here, it will not be absorbed. And a Western diet contains about 15 milligrams of iron. So if you see that we absorb 10% of non-heme, 30% of heme, you can around this sort of between 1.5 to 2 milligrams is absorbed, and that sort of makes up for those losses that I showed in the previous image. And where this will take place is in the duodenum and upper jejunum. Here's just a little picture of some of the iron supplementations, and we're still going to go into the iron formulations a bit later. But if you look at the normal absorption, you could kind of postulate that there's 3 forms that we can absorb iron in. You can either give it in the heme form, and it will be absorbed. You can give it in the ferric form, it'll need to be reduced and then absorbed, or you can give it in the ferrous form. And this is more or less what you see in iron supplementation. You would think that heme iron, with better absorption would be the ideal form to give. 30% of it is absorbed. And there are heme iron formulations, but they haven't really been shown to be much more effective. And this is one of the conundrums of iron formulations, is that with a lot of the background knowledge we have and a lot of the different formulations we've made, to a large degree, there's not one formulation that stands out, or at least as far as I could find. Let's look at some other factors. So we've seen how iron is absorbed and where it's used. What are some other factors that affect iron absorption? Well, there's a few things that can increase iron absorption. As we've said, the form of iron that we give, heme iron being more absorbed. Another a vitamin here, vitamin C, increases iron absorption. Well, I'll show you a little image on that now. And then meat and fish. Not only do you have more heme iron in these, but the amino acids present in these can also chelate the iron that you receive and sort of protect it from becoming an insoluble form. Whereas many of the things that decrease iron absorption, perhaps I want to touch on PPIs. So PPIs will increase your gastric pH. Gastric pH is important for the function of the duodenal enzyme, the cytochrome B enzyme. So this is the enzyme that's responsible for that reduction process that I showed earlier. So this is sort of how PPIs would reduce absorption by increasing gastric pH. These other substances, phytates, polyphenols, and soy proteins, well, they all have molecules in them that form insoluble substances when bound together with iron. So if I just put this statement up here, we can see that iron needs to be conjugated either to vitamin C, amino acids, or sugars to prevent the conversion to an unabsorbable form, which is this ferric hydroxide form. So many of the iron formulations also use this. They bind the iron to some of these substances to protect it from becoming this unabsorbable form, to try and improve absorption and decrease side effects. Well, I've mentioned side effects now, so let's talk about that. So some of the biggest issues with oral iron, it's a very safe medication, but it's a very troublesome medication as well. So there's a large amount of gastrointestinal side effects. We can see here some numbers. I mean, obviously, depending on which formulation, which study you look at, these will vary widely. But in general, constipation, nausea, and diarrhea, gastrointestinal complaints, quite common, together with a metallic taste. And it's important to remember that many of these are dose dependent on the amount of iron you give. So this just tells us that there is something we can do to reduce these. Are there specific formulations that reduce these? They are claimed to be, and in some studies they are shown to be, and I'll touch on it a bit later. But just to note that it's difficult to get around these, and I sort of feel like some of the more important ways is explaining it to your patient and remembering the dose. Why do we get these complications? Well, predominantly due to inflammation, due to free radical formation of iron, due to the excess iron, as well as a change in your gut microbiota. So the question is, when should I give oral iron? And there's many ways to think about this, but I think in general, you can think of, oral iron is a safe medication and it's generally an inexpensive medication. So you should always consider it you have a definitive iron deficiency, you should be considering oral iron therapy. So I think it's important to think, when is my patient not a candidate for this? When is there something else going on where oral iron is not going to work? Because if it's going to work, I would think you should give it. So if we look at some of the comparisons between oral iron and intravenous iron, well, we can see that they're both effective. I mean, if the patient's iron deficient and you give them iron, it should work. There's a few caveats here, as I'm sure most of us are aware. If we look at some more benefits for oral iron, it's very low cost and very low risk. However, there are some negative points here. It's got gastrointestinal side effects, leads to low adherence, may be inadequate. I mean, if the losses are excessive, you can only absorb so much iron from oral iron. If the losses are more than that possibility of absorption, it's not going to help. It takes longer to treat the iron deficiency, to improve the HP. And the total cost, we say it's very low cost, but depending on what product you use and over how long you use it, the total cost can add up and can sometimes be in excess of IV iron. So IV iron, it's an amazing medication and one that can work very well for a large amount of patients, and something we need to keep in our arsenal. It's got a more rapid correction. You give a large dose of iron. Most formulations these days, and it's recommended to give formulations where you can give a total dose infusion. Your adherence is assured, the iron's going in, and there's no gastrointestinal side effects. But they do need some monitoring. There is a small risk of allergic reactions and generally more expensive. So when should I be giving this IV iron? Well, it has a list of things where you can consider it. If they cannot tolerate gastrointestinal side effects, if there's severe losses, we have this in some of our clinics, or patients with HHT, or if there's really heavy menstrual bleeding, or whatever the case may be, if the losses exceed what oral iron can help with, it's not gonna, you can move to IV iron. If they can't absorb it because of gastrointestinal sort of reasons, if you need a quicker recovery prior to surgery, if they're in the later trimesters of pregnancy, or if their anemia is quite severe, or if they're relatively symptomatic. And last but not least, if you failed oral iron therapy. Don't bash your head against the wall too much. If it's not working, there are other options. So if you've made your decision for oral iron, you realize that you've weighed the pros and benefits of giving the oral iron, what are some things you can do besides the formulation to try and ensure success as far as possible? Well, we can try some things to improve absorption. You'll see this is mentioned through many guidelines and so on, is to avoid enteric-coated or time-released products. As far as I know, I don't think many of the products are like this anymore. I believe there were some older products that had this enteric coating, which would take the product past the duodenum, past the upper jejunum, and then release the iron, and you would get obviously no absorption if the iron is only released past those areas. One thing that we can consider doing is to take iron separately from food that may impair absorption. And you'll see all of your good breakfast things. So you shouldn't really have it with your breakfast if possible. We'll talk about this as well. You should minimize exposure to medication. So if the patient is on a proton pump inhibitor, is it really necessary to be on this medication? Because this may be a time to discontinue if it sort of wasn't started for the appropriate reason. And you can move your oral iron therapy from these time frames as well. And you can try and take it with these supplements that have increased absorption. Vitamin C, we always talk about, take it with vitamin C, take it with some orange juice. Well, we'll look at that just now. Is that really the truth? So you can try and improve the tolerability as well. So not only do you want to improve the absorption, you want to see how can I get my patient to tolerate this and ensure that they actually drink this medication. Well, less frequent dosing. As I mentioned, the side effects are dose dependent, and there's very nice things about this dosing, which I'll show as well. So less frequent dosing, alternative day dosing, or even longer time periods if necessary. Taking iron with food, we know this may decrease absorption, but not taking the medication is the lowest absorption you can have. So if the patient can only take it with food, this is a valid strategy. Using a lower dose, so lowering the amount of elemental iron. Sometimes with tablets, it can be tricky, but if you've got some liquid formulations, this is something you consider, using lower amounts of a liquid formulation with your patient. treating constipation, either with dietary education or perhaps with medical. So let's look at vitamin C. This is something that's always come up quite a lot, is that vitamin C is good for iron absorption. And here is a study showing this, showing the sort of biological evidence. So they looked at, does vitamin C, ascorbic acid, improve iron absorption? So they looked at, they radio-labeled iron, gave it to patients, and then tested how much of this iron was on the reds, found within the red cells. They used the patient taking water as a reference. They used a lower dose of ascorbic acid, higher dose. They asked the patients to take the iron with coffee and to take the iron with breakfast, including coffee and orange. They tried to mix the things together to see, can the ascorbic acid overcome this inhibitory effect, and water in the afternoon. And they found that this low dose, 18 milligrams, increased your iron absorption by 30%. So, but if you went to higher doses, this 500 milligrams didn't really further increase. So the low doses of ascorbic acid improve absorption by 30%. Coffee decreases it, no surprise there. And the ascorbic acid, together with the coffee and breakfast, can it overcome this inhibition? It could not. Right. So basically, the recommendation is that if you're using, and they did it with ferrous iron, this is always a caveat that you must take into consideration. What did they use? Can I really apply this everywhere? And it's a very, very tricky situation in oral iron therapy. Well, it should be consumed in the morning, away from meals or coffee, and with ascorbic acid-rich food or beverage. So that recommendation seems to hold up. Well, if we look at some randomized control data, what did they find here? Well, they actually found, I won't go into too much detail. Here's the study here, and we can all go read it as well if you want. But they actually found that when we look at, did it increase the patient's HB and ferritin? Did these values actually increase? Well, they actually showed equivalence. Didn't increase. There was no significant, there was no significant improvement, right? If you took iron together with vitamin C or not. But they also did say there were no significant differences regarding side effects. So I just wanted to put this in here saying, well, there is a financial harm if you're going to give vitamin C, but in terms of adverse events, there wasn't really harm in giving it, right? So we have biological evidence, but this data seemed to be against it. If we look at review articles, reviewing multiple and doing a meta-analysis, they actually said that it did increase HB and ferritin. Adding vitamin C did increase it without adverse events, but I basically said they can't recommend giving it. So what can we do now? We've got some biological evidence. It seems like in clinical situations, it doesn't really help that much, but the adverse events don't seem to be worse. Well, let's go look at some guidelines. And I want to start with some local guidelines, this excellent document that I'm sure all of us are aware of. And what do we say about ascorbic acid? We actually say no. We looked at that clinical data and decided we're not going to make a recommendation of ascorbic acid, but we are going to say the patient should be in a fasting state when taking oral iron. If we look at what the Americans say regarding this, well, they actually quote their biological evidence and they say you should add vitamin C to improve absorption. No tea or coffee within 1 hour and on an empty stomach. Okay, what does the authors of Up to Date have to say about this? Well, they say either way, and I think this is a valid recommendation. Speak to your patient. I think it possibly could help them knowing know that, you know, if I drink my orange juice together with this, I'm helping. If it makes me feel unwell, though, if it makes me feel as if I can't drink this iron, I don't have to drink the orange juice. We don't have to force anyone to do it because, yeah, there's not strong data that we should be using. So I think that's good to know that you can explain this to the patients, that there's biological evidence. Clinical data doesn't seem to back it up that much. Give it a try. If you don't feel well, feel free to stop it. Okay, so we've covered some vitamin C and the fasting state. Let's look at some of the iron formulations, and this is where things get very tricky. So here's that table from earlier, and we can see here's the formulation. So the ferrous salts, that's Fe2+, bound to some kind of salt. These we know, these are one of the ones that we commonly use, and what do people always say about them is that they're relatively inexpensive, they're widely available, but they've got gastrointestinal side effects. Let's touch on some of these other ones. The polysaccharide iron complex, carbonyl iron, iron protein succinylate, iron amino acid chelates. Well, heme iron is its own sort of thing. I can understand the reason for making it, but it's expensive. The reason is that the absorption should be higher, and it hasn't really shown to be much more effective than ferrous iron. All of these combinations, what they're trying to do is trying to reduce side effects by binding iron to some other kind of molecule, whether it's an amino acid, whether it's some kind of protein, whether it's some kind of complex molecule that they've made. They're trying to bind iron to this to reduce the irritation of the gut, make sure the iron is released in the perfect area and is absorbed. The only real recommendations that you'll see, and we'll look at this, there's not one that really stands out above any other one as far as I could see. And we'll look at this as well. I sort of just made this table from what's available here in South Africa in the state sector. And I won't stay on this too long, but I just wanted to show that when we look at our iron therapy, something we should just keep in mind is that the elemental iron, that's the amount of iron in there. The rest of the milligrams is the amount of salt or amino acid or whatever it may be. So when we're thinking of adjusting doses, going up or down, we need to be keeping a careful eye on the elemental iron. So that's the one I've put in brackets here. So I just wanted to do a little comparison here, just so we can see, an equation that we can see. So if we take a patient, we've diagnosed them with iron deficiency. We've decided, we're going to treat this person with oral iron, and we're doing everything to improve absorption and improve tolerability, decrease side effects as far as we can. And just for interest's sake, we're treating them for 6 months. We're giving them a daily dose, and we're not going to match the elemental iron. We're going to say, let's give 1 tablet a day, which is a reasonable approach. You give 1 tablet a day, and we can, follow up and adjust from there. So this comes out to more or less 180 tablets. So let's compare these two medications. Ferrous sulfate, the cheapest of the cheap, and ferrous bisglycinate. This is one of the amino acid combinations. This one is commonly found in sort of the pregnancy medications here in South Africa. So if we just take a look at this, just at the 1 tab, and these, there's different formulations and so on. So in the ones that we have here in the state sector, you can see that you get 34 milligrams of elemental iron in 1 tablet of ferrous sulfate. You get 50 milligrams of elemental iron in 1 tablet of this. If we multiply these two values by 180, we get 6.1 grams of elemental iron over the 6 months. Here we get 2.7 over the 6 months. The total cost over 6 months is 156 Rand for this formulation. The total cost is 1,476 for this formulation. Remember, you're actually getting less iron as well here. Perhaps the tolerability is better, perhaps not. So if you actually look at Rand per elemental iron, like you actually need to double the amount of tablets of this medication to get the same amount of possible absorption. Well, this one's 55 cents per milligram of iron. This one's way less. This is 20 times the price. So just to show that this is something we need to consider. Ferrous sulfate has been shown to be a good medication in many studies. And I think probably a good starting point for your treatment. I just wanted to give a special mention to sucrosomal iron. As far as I can see, this is not really talked about much in the USA. I think it may not be available there, and I'm not really sure why. This is a special formulation of iron, which I don't completely understand, but it's got this iron pyrophosphate center in the sucrosome, and it makes these sucromeres. And what it comes down to is that, one, it's protected from it's protected from gastrointestinal release of the iron. So the iron's not released in your stomach where it can cause side effects. Right? This is all in vitro studies, right? So, and it seems like there's some kind of other method of absorption of iron, not through that DMT pathway or not through the heme pathway. It seems like there's some transcellular mechanism to absorption, which makes it seem that this iron molecule can be absorbed independently of hepcidin, as far as I can understand. So this is one that I thought this could, and it is available in South Africa. Could this be an intermediate option prior to IV iron? Or if there's a patient where you think there may be some increased hepcidin, due to some kind of inflammatory process or so. Is this maybe an option? And here's looking at some studies on this. They compared high dose of sucrosomal iron versus IV iron in people that have failed iron sulfate. And they say, obviously we can all go check these studies as well, but it's comparable to IV iron and it's got low side effects, and they took it with food. So that's quite interesting. And if we look at this also versus intravenous iron in anemic cancer patients without iron deficiency, but they're getting EPO. So they're trying to overcome that sort of functional iron deficiency, as far as I can understand. And they all respond when they receive, or the response is similar to IV iron together with the EPO. So very interesting, but I spent quite a lot of time looking at various studies, and we're still going to look at some, but something that kept on coming to me is there are a lot of formulations and a lot of studies. And I took this slide from Dr. van Marle, one of my colleagues, where she talked about the prevalence of iron deficiency. And this is a huge problem. Iron deficiency is a huge problem. Iron deficiency anemia, 1.9 billion individuals. Non-anemic iron deficiency, even more people. So, and if you think about some people that you may want to put prophylactically on iron, this does just show me that there's a huge market for oral iron therapy. So this is just something we need to keep in mind when we're evaluating which formulation is truly the best. And I came across this when I was looking at some of these studies, because as you'll see, most of the guidelines, the large guidelines, don't recommend a specific formulation. But then you find these studies where, these oral iron therapies, some are much better than others. That the tolerability of this ferrous sulfate with mucoprotectose, the side effects are so low, 4.1% tolerability. But if you just go look under the transparency section, which is not an issue, many of these studies are funded by pharmaceutical companies. And it's just something to keep in mind. Why is this not penetrating the market? And this is something that you got to keep in mind when you're looking at these studies. If we look at something else, here is another example of this: iron protein succinylate, superior effectiveness. If you go to the transparency, you can see pharmaceutical companies. If you look at randomized control data, doesn't seem like there's too much difference between these formulations. These are relatively older formulations, but you can see the patients that became non-anemic, pretty similar between groups. Fumarate was actually the best that became non-anemic, but they did have some more adverse events. And a large dose of iron, 200 milligrams of elemental iron, is quite high. So it looks like the actual clinical benefit of these seems relatively similar, and the side effects was only ferrous fumarate with the highest side effect profile between these molecules. Here they compared against iron polysaccharide complex in young children, and actually found it was worse. So 80 patients received ferrous sulfate for 12 weeks, greater increase in HB than those receiving the newer molecule. So this just goes to show that ferrous sulfate is a good medication. And I think this leads to here's some more of this data that I can just quickly show similar findings, that this is amino acid chelated versus iron salt, comparable, but this amino acid may have faster improvement and better tolerated. So this is the one that is found in most of the pregnancy-related medications here in South Africa, at least. But if you go look at if you look at the guidelines, there's no, basically what you see everywhere is that you should avoid those modified release molecules, and iron salts are the standard of treatment. The Americans, no single formulation of oral iron has any advantages over another, and they actually specifically say ferrous sulfate is preferred as the least expensive. Up to date mentions that same enteric coated. They do not use they're not using these fancy preparations like heme iron or so. All formulations are equally effective as long as they're taken. And I think that's an important point, that it's easy to get intimidated and lost, sort of, or for me at least, between the different formulations. But to know that I think ferrous sulfate is a fairly good starting point. Keep an eye on, you can prescribe whichever dose you can prescribe to your patient. There's many formulations of it, which makes it even more tricky. And ask your patient to bring their tablets with when they come to follow up, so you can see how much elemental iron is in that tablet that my patients get, because it's quite tricky to remember exactly all the formulations available. And then perhaps if side effects are an issue, you can try and reduce the dosing you can reduce the amount of elemental iron, or you can switch to another formula. There are other formulations which you can consider switching to, but I would be hard pressed to give a specific recommendation for one of the newer formulations. If we look at the dose of iron, here we can see, look at these large doses. So this is originally how iron was dosed, 3 tablets per day. Initial recommendation, 60 to 70 milligrams, TDS, BD, getting an overall daily dose of about 200 milligrams. And then, the HB increased in these patients, but the side effects were quite bad. So let's look at the impact of hepcidin, and everyone loves looking at these studies, and I also think it's super interesting. So the idea being, if you give me oral iron today, I'm going to absorb some of that oral iron. My body's going to see I've got a lot of iron and increase hepcidin. And these hepcidin levels will actually be increased tomorrow. So isn't it perhaps, and then decrease on this, if there's 2 days in between, then they actually sort of return to baseline. So should we not rather give it on alternative days? And there's many studies on this, but I quite enjoyed this one where they did a few different things here. So one, they looked at different doses of iron, 40, 80, 160, 240 milligrams of daily dosing. And they either gave it on alternative days, or they gave it one day after each other. In this arm here, they looked at the same dose. They gave daily dosing here, and in this arm here, they looked at BD dosing. What can we see that they found here? And these are some really interesting tables. Just remember well. So if we look at the transferrin saturation, we can see that if you receive the dose here, the transferrin saturation increases and then drops down to baseline about after a few hours to a day or so. And you can see it drops down to baseline between the daily dosing as well. And this is at 40 milligrams, very low dose. You can see the similar thing here with the higher dose. So this is only those 2 doses that I'm showing here. If you look at the hepcidin, it shows it quite nicely here that if you receive a single dose, your hepcidin goes up and then returns to baseline sort of 2 days afterwards. You can see here on this daily dosing, look, the hepcidin is not at baseline yet, and you're already taking another dose. But if you look at the 40 milligrams, not really such a large spike in hepcidin. So this lower dosing is definitely an option. Something else I just wanted to show that I've come across. So one thing to keep in mind when you're doing iron studies is that if your patient takes a tablet that morning, we all know that serum iron will be affected and is not that trustworthy of a parameter. But remember, transferrin saturation is calculated using the serum iron. And you can actually get some falsely elevated results if someone has taken the iron tablet on that day. So just something to keep in mind if you're seeing something that's a bit unexpected. In terms of the ferritin, generally it's said that ferritin doesn't get impacted by oral iron. And I mean, at this 40 milligram dose, you don't see too much going on. But interestingly here, when you go to this higher dosing, I mean, the ferritin increases and then drops down at a higher baseline. So, I mean, there was some increased iron storage, but, it went sort of, the ferritin went from probably around about 10 or so up to almost 40. So this is just something to keep in mind as well, that, I mean, as far as I've seen, oral iron therapy should not affect your ferritin values, but I mean, this is quite clear that your ferritin goes up and transiently goes up and then returns to the true value a few days afterwards. So, just something to keep in mind if your iron studies are not perhaps going completely with what you think is, repeating these things on an empty stomach or not anywhere near oral iron therapy if possible. Here they looked at the amount that's absorbed between alternative and daily dosing. So this is the alternative day dosing, and actually more of the iron that you drink is absorbed. If you take it on daily, you have less absorption of the iron. So as your doses increase, obviously you do have more iron, but I mean, you have to take a huge dose here for not that much of an increase in absorption of iron. So what did they make with these recommendations? Well, they said that iron doses of 60 to 240 milligrams elevated hepcidin for 24 hours with lower absorption on the subsequent day, as we can see, a lower absorption on the daily dosing. And they actually make a recommendation for alternative day dosing. And they said there's more efficient absorption at lower doses, but less overall. So, I mean, higher doses, you will overall get more iron, but as a percentage, you're absorbing less. More of it is just going through your GI tract, causing side effects. So it seems as though, at this stage, we should just be giving alternative day dosing. There's less side effects, and the absorption in terms of daily versus alternate day seems more or less the same. Well, if you look at clinical practice, if we look at some reviews on this, in actual patients, it seems like there's no increase in HB, no difference in HB. It's not like it increases your HB faster to do alternative day, but there is indeed less side effects with alternative day dosing. To note, this is look with ferrous salts only. So let's look at some of the recommendations then, because it seems biologically that, alternate day seems the best. So what do we say here? We say lower doses with infrequent administration. So you sort of leave it in the hands of the doctor as well, saying, you don't have to give these huge doses, and you don't have to give it TDS, for sure not, but you can even give it BD. The Americans say daily or alternative day. They say once a day at most. Every other day may be better tolerated for some patients. Up to date, similar thing, daily or alternative day, not multiple doses on one day. And then they actually say they give 1 tablet per dose, because calculating the exact amount that you can give can be time consuming and difficult to get to. I don't know, if you want to give 80 milligrams of elemental iron, it can be difficult to know exactly which formulation the patient's going to get and so on. So I think, to me, this makes sense. You start them on 1 tablet, you ask them to bring their tablets with, and if there are issues, you can kind of look at, how much is the elemental that they're actually getting? Generally, 60 to 100 milligrams of elemental iron is a good dose. You can go lower. You probably can go higher as well if they're tolerating it well. But this is sort of more or less where you're aiming. So if your patient has no side effects, they're feeling good, but the HB, it's maybe on the way up, but it's taking a long time to increase. You ask them to bring their tablets along, and you see, they're only taking 30 milligrams of elemental. I can actually recommend they take 2 tablets a day, or they can, alternate it with 2 tablets today, 1 tablet tomorrow. However, if your patient's HB is increasing, they've got severe side effects, you ask them to bring the tablets with, they're drinking 120 daily, you can say, whoa, let's maybe go down to 120 alternative days, or we can even go to 60. If it's easier for them to remember to take the tablets every day, you can say, okay, let's go down to 60 every day. So I think it seems like quite a pragmatic approach with all the variations in the available formulations. So if we look at dosing in children, I just wanted to put this in because some people may wonder about this. Generally lower doses, less than 5 milligrams per kilogram per day, improved the HBs. I remember there's quite a confusing study. So combined with treatment durations, either less than 3 months or more than 6 months is optimal. Not confusing findings in this. If you treated someone for iron deficiency between 3 and 6 months, the HB didn't improve as much as less than 3 months or more than. Just shows that these studies can sometimes be very confusing and tricky to do. But I think the dosing seems reasonable. And up to date even gives some lower doses that you can use in children, 3 milligrams per kg. But remember, this can be adapted as well, depending on, are they tolerating it well? And perhaps you need a little bit more iron to be absorbed, or are they not tolerating it well and we need to perhaps decrease? For how long should you be giving these treatments? Well, you should aim more or less for a ferritin of more than 50, but there are some caveats to this, depending on what the condition is and so on. And how long this is going to take, well, it's a little bit dependent, it can take up to 75 days. That's sort of 2 months if you look at this, or this calculation that they've done here. So how can we evaluate the response to this therapy? How do we know if we're on the right track or not? Well, things that will increase initially is pachyphagia, if it was present, very shortly. As soon as they start drinking the medications, they can improve. They will generally just be feeling better after a few days. Restless leg should improve after 3 days. And you should start to begin to see reticulocytosis after 7 to 10 days. This is a very nice recommendation, that the HB after 1 to 2 weeks should begin to increase. There's actually a recommendation, if you don't see an increase of 1 gram per deciliter at 14 days, it seems as though the patient will be unlikely to respond, and you may want to consider IV iron. So this is maybe not a bad time point to review your patient at. The HB deficit should be halved at 1 month and normally normal by 6 to 8 weeks. And then the ferritin you can look at after, 3 months or 2 months or so, depending on when this HB improves. if the HB has only improved, last week, I think you can wait, 2 to 3 weeks before you check a ferritin. I don't think there's, that's sort of like a pragmatic approach that you'll have to take. But this is quite a nice recommendation that you can look at. Obviously, clinically, very quickly, the patient can monitor themselves. And then if you review them after 2 weeks, the HB has stayed the same or the HB has dropped, you're probably going to have to try IV iron. Okay, if we overall look at an approach, there are many of these approaches. I don't want to bore you guys too much with these because we can all look at them. This is actually quite an old approach, which I like from the New England Journal of Medicine. In 2014, they already had ferritin at less than 50 here. I mean, there's lots of talk about ferritin cutoffs and we need to raise the bar. Yeah, they had it at 50. Very interesting. So you confirm iron deficiency, you got to look at the cause. What's the cause of the iron deficiency? There's not a diagnosis. You look for possible, should you be treating with IV iron? If so, you move on there. If not, if you're going to give oral, you give your oral. You look at these factors to try and improve absorption both of these, and not decrease absorption. Are they tolerating it? Yes, you can look at the ferritin after 12 weeks or so. If the ferritin is more than 50, happy days. I mean, obviously, all of these recommendations depend on what's the cause of the iron deficiency. We shouldn't lose sight what's causing this. This is just a symptom. Here's a relatively new recommendation, and they also mention here that oral iron is the first-line treatment for most patients. If not tolerated, we can move on to others, but I won't waste too much time here. I just wanted to put 1 or 2 slides on in pregnancy. As we know, there's been many studies looking at anemia or iron deficiency in pregnancy and a multitude of problems. Increased bleeding, decreased IQ in children, and an increase in autism spectrum disorders and so on. Basically saying that we need to be looking at pregnant ladies and making sure they're not iron deficient. It's actually interesting. Should we screen all pregnant women for iron deficiency? Well, I looked at this gentleman here, I think it's Professor Michael Auerbach. Initially at this recommendation, I think it was in 2013, he specifically mentions this. He says, he was looking at giving a clinical opinion on this. And he actually said he believes that you should look at it in every pregnant woman. But there were no international guidelines to make this recommendation. So the international guidelines were saying no. Looking at a cost-benefit ratio and so on, it didn't seem like they could make the recommendation. But subsequently, in 2024, the US Preventative Services Task Force said they can't recommend, but the American College for Obs and Gynae said yes, you should. Oh, they actually said you should screen for anemia. If there's anemia, then only look for iron deficiency. A little bit strange. And then if we look at more European guidelines, they recommend screen all pregnant women for iron deficiency. And I think this just shows that sometimes to get the data behind a rational kind of thing is difficult. And to make a large guideline, obviously costs will be increased if you screen every pregnant woman for iron deficiency. There will be more laboratory costs. And how can you establish benefit? It's very difficult. It's going to be very difficult. But I think these recommendations, to me, just as a pragmatic approach, if someone I knew was pregnant, I would want them to check, are they iron deficient? We can do something about it. I'm going to be wrapping up soon. So what are some things I can mention about patient education? I think this is a very important part. This treatment is something you do together with the patient. You should tell them what the signs and symptoms are of the anemia and the iron deficiency, and tell them, listen, this should get better. You should tell them what the causes are and how are we working them up. This is a symptom. What are we doing to find out what the diagnosis is? How did we specifically diagnose this? What tests did we do? What's our plan? Why are we giving them oral or IV? And then just mentioning that the oral iron therapy should be put somewhere out of the hands of children because iron overdose is a problem. We should be telling them about our treatment plan. Like I mentioned, are we giving oral? Are we giving IV? Maybe this patient is one of the few patients who needs a blood transfusion. Maybe they are really symptomatic and they need a blood transfusion. And then why are we doing that? Oral iron, what's the dosing? What side effects? As we mentioned, what can we do to improve absorption, improve tolerability, try and decrease side effects? And when are we going to follow them up? And what can we do? I mean, there are options available. We can mention to them, we're going to start on this medication. It's cheap as chips. If it doesn't work out for you, we can try something else. If that doesn't work out, there is IV iron. And in the meantime, we're finding out why. Why are you iron deficient? We tell them about the different types, as I mentioned here, and what we can do, and let them make some shared decision-making together with us. This is almost my last slide. This is just a little image that I think, just to remind myself that I think oral iron therapy is one of the great sort of struggles that's coming into medicine, where we have the struggle versus data versus the art of medicine, where it would be lovely if we had strong data to say, use this formulation at this dosing for this long, and that's 100% proven. But I doubt we're ever going to find that. Maybe we will one day. And I think this is where we need to have good knowledge of what's going on, and be able to give some good recommendations together with the patient. And just know that there are options available, and that the art of medicine is strong and alive. So we're back to our case here. I'm not sure if anyone wants to give some input, or if I should just say what I think regarding these questions. Is there any input regarding this, or should I maybe just make a comment and then look for any questions?
Evan, I think you can comment, and then we'll take questions thereafter.
Perfect. Thanks, Prof. So I think here at this, we can see that the iron deficiency has steadily worsened. So I think places for oral iron therapy will be most certainly these 2 time points, right? The patient is likely not or it could be symptomatic from the iron deficiency, but it's not an urgent matter. Epistaxis, you need to be sorting out, getting an ENT consultation and sorting out the epistaxis as well. Once we're getting to these time points, however, we need to be thinking, perhaps, especially if the patient is quite severely symptomatic, perhaps IV iron is more necessary here. However, if the patient is asymptomatic, you could even, and they have not received oral iron at any of these time points, and the bleeding is sorted out, you could even try oral iron here. There's no issue. You discuss with the patient, you give them a trial of oral iron. So I would think at any one of these time points, you could attempt oral iron, depending on the bleeding. How is the bleeding going, and is there any side effects or any contraindications in terms of tolerability or so? Is there a specific oral product we would recommend? I think we could safely say there's not a specific one. I would give ferrous sulfate in the example of the patient that we gave you, the young gentleman with hemophilia. I don't think there's indication for anyone else, so I would start them on 1 tablet of ferrous sulfate. If they came to me at this time point, I would go for alternative day dosing. We have, the HP is not too low. Yes, the iron stores are low or decreased, so we want to improve these. He may be symptomatic. So alternative day dosing here, we don't need to get that much iron into the patient. We're sorting out the bleeding. And we don't want any side effects. Whereas perhaps if the patient's coming to you at this time point, you may think, oh, I would really like this HP to increase a little bit quicker. So if I'm going to give him oral iron, perhaps I'll go with daily dosing at this, but I would still probably start with ferrous sulfate. If the ferrous sulfate tablet that I showed earlier in that table was about 30 milligrams of elemental iron, you may even want to give 2 tablets of that. But you may not be certain of what formulation you have initially. So I would think start the formulation, follow them up in a couple of weeks, look at what they bring to you. If I saw his HB went up to 8.5, but he was taking 30 milligrams, I would even say, let's try 2 to 3 of those tablets a day. Tell me how your side effects are. If it's not working for you, you can go to alternative dosing. So I think that's just nice to show the spectrum of how you can dose the patient. If they've got side effects, we've spoken nicely about, depends a little bit on what we're talking. If they've got severe side effects at this end of the spectrum, perhaps you're going to be more willing to jump on IV iron. You don't want to mess around too much with trying different formulations, decreasing the dose. Perhaps you'll be a little bit closer to going to IV iron at this end of the spectrum. Whilst over here, if they're having some side effects, let's lower the dose. We can try a different formulation. Let's go less frequently. Even less than alternate days is also an option. 3 times a week, twice a week, it's also an option. So I think that hopefully answers some of the questions. And I believe that that's where I'm going to call it, if that's all right. Any questions that I can take?
Evan, thank you so much. That is a unique overview of the very, very important topic, and surprisingly complex. If you look at all the nuance, or let's say surprisingly nuanced. And I do think to some extent complex as well. Really appreciate it. Thanks for all the hard work in putting this together. I'm going to ask you to just put your slides back on, because I do want to go back to your table and maybe just make a few general comments, and then we'll look at the chat. So thank you for sharing this. I think there's a couple of helpful things. Now, that last table that you just had there, that one with the hemophilia bleeding patient. Yep, there we go. So one of the things I just want to point out here, which is a very important message, and it's confirmed again with a study that Dr. Andrea Coetzee is now doing for her master's degree. Look at the normal MCVs. Even in the patient with an HP of 10.5, 7.9, you still have an MCV above 80. It's unfortunately a big misunderstanding that a normal MCV excludes iron deficiency. It's more the reverse. If the MCV is less than 80, then it is very likely that the cause is iron deficiency. I mean, it would probably be 90% of patients. There will be a few thalassemics thrown in there, maybe even some patients with iron restriction from chronic inflammation. But what we see here with a normal MCV, some studies have shown us that 40% plus of patients with iron deficiency have a normal MCV. And I really want everybody to look at the HPs here. The low HP normal MCV, we can see that it dropped from 92 to 81, but it's still in the normal range. Jenny Hull in the comment section made the comment about looking at RDW as well. And the RDW red cell distribution with is also quite useful. It's often increased. Unfortunately, it can also be increased with other conditions or deficiencies, but it's certainly something that can give you a clue. I see, Claire, you also wanted to comment on those MCVs. Do you want to add something? Please do.
I didn't want to add anything. I just, at every opportunity I get, I want to sort of bust the MCV myth, and that,
Very good.
you don't only test for the ferritin or the iron stores when the MCV is low. You need to have a high index of suspicion and think of iron deficiency regardless of what the MCV says.
Okay.
So yeah, I just actually wanted to say, you jumped in and said the same thing I wanted to say.
Okay, fantastic. Thank you so much for that. Great. Then anonymously, somebody commented in the chat, Evan, about, or asked the question, do children still experience discoloration of teeth with the use of oral iron syrups? Don't know if you want to comment on that, but I think the answer is yes, especially with ferrous sulfate. And you must look behind the teeth. You often see it. I saw Stewart Gibson in the room. Stewart is also very, very involved with children and dental work and giving anesthesia, and he's also doing research on iron deficiency in children with dental problems. Steve, I don't know if you have any comments on that. You can either speak up or put it in the chat. You're very welcome. Your experience with children and discoloration. Sharoch just emphasized the point again about the 20 to 30% elemental iron, which I think you mentioned in the beginning, Evan. Which, yes, is important. I think one should also recognize that the body has got limitations in how much iron it can absorb on a daily basis. I think you showed us those graphs nicely, but generally speaking, there's only so much increase in absorption that the body can do. Let me see. Right. Johnny Mishlangu, Prof. Johnny, who's the doyen of hemophilia in South Africa, he says, in our local data, the prevalence of iron deficiency anemia in inherited bleeding disorders was 7% compared to, Johnny, you must help me here, non-IBD. Are you referring to non-inflammatory bowel disease or non-inherited bleeding disorders? Don't know, is Johnny still in the room?
I'm still here, Venon.
Oh, great, Johnny. Yes, go ahead.
Even this is very informative and certainly gives a different perspective. One of my master students just completed their MEd, looking specifically at iron deficiency, and I'm actually quite pleased that you're using that as an example here. So the prevalence of iron deficiency was about a third when compared to non-inherited bleeding disorder population. These are patients also in our hospital for other reasons other than hemophilia and van Willebrand's. But I think the point you made is quite valid, that one should not just be looking at blood parameters. One should very early identify the low iron stores reflected here by the ferritin and start to think about iron replacement at that stage.
Thanks very much, Johnny. And I think it probably reflects the good care bleeding disorder patients receive. That may be the reason why they are probably better treated and better informed by people who know what to look out for. So very well done on that too. Look forward to that study being published. David Milan says, simple question, should you use ferrous sulfate daily? Won't it increase Epsom, decrease absorption of iron? Is that the reason why some recommend the use of iron alternate days? I think Evan spoke to that point where both daily or alternate day iron can be used, perhaps with less side effects with the alternate days. There's variation in the response rates. Some studies have shown a greater increase in ferritin with alternate day, but not necessarily a greater increase in hemoglobin. On that note, Evan, I was just thinking, if you look at the studies and that specifically the meta-analysis you quoted on ascorbic acid, sometimes good to look at the details. And it's also why we didn't recommend ascorbic acid in the gastrointestinal guidelines. I think Wayne Simmons, who was the first author on that paper, is in the room. If you look at the actual increase that you got with ascorbic acid from the meta-analysis, your ferritin only increased by 3. So like from 30 to 33. Your HB increase was 0.13, like from 10 to 10.1. Now, if you think of the extra cost, and it's also important to mention that some of the studies have shown that if you add ascorbic acid, you actually increase side effects. Because it's also a reducing agent. So you change more ferric iron into ferrous iron so they can get more diarrhea, etc. So I think it's just something that one should keep in mind as well. Otlile Sitlogelo says, thank you for the presentation. What's your thought on iron screening for every pregnancy, seeing that there's not a lot of data to make an evidence-based recommendation? Evan, do you want to stick your neck out? Otherwise, I will.
Prof, I'll say that I think I briefly mentioned it, that it's going to be difficult to get, I think it will be difficult to make a data-driven point as to why it would be good. But I think just as a, a rational thinking kind of point, to me at least, I think you should screen them all. There's recommendations saying you shouldn't screen. There's recommendations saying you should first look for anemia and then iron deficiency. I mean, to me, that doesn't seem to make very good sense, but there are also recommendations that you can screen them all. I can go back and show it. So to me, I understand it will increase costs for sure, but I just think it will be very difficult to tell a pregnant woman you're not going to screen her, catch her late in pregnancy, and there's some kind of complication. I just feel like you're looking for trouble if you don't make that recommendation. And personally, I think you should. What would you think?
I would make a very strong case for screening. I think one should also just understand what they are trying to say. I think the screening is put in opposition to just giving oral iron supplements to all patients, which is part of the normal protocol. But that assumes that is enough. And I think the problem there is, and the Canadians have shown this very well, that this is actually quite amazing, this particular study. What they showed was if you supplement iron in a patient population where they had virtually 100% adherence, which is unbelievable, but that's what they got. By the end of pregnancy, 80% were iron deficient. So I don't believe only in screening. I also believe in monitoring. And I'll tell you, I mean, I can give a whole lecture on this, which I won't do now, but I'm gonna use a example I've never used before. What is the prevalence of hypothyroidism in neonates? Between 1 in 2,000 and 1 in 4,000. We screen them all because of the implications of intellectual disability, right? What did you just show us? For every 100 people that are 100 children born from an iron deficient mother, there will be 2 that are intellectually disabled, 2 more that will be intellectually disabled compared to those who were not iron deficient. You can show that picture again. You also showed us 3.1 versus 1%. That's 2% more. You also showed us 2% more will have ADHD. 1.4% more will have autism spectrum disorder. So you count all of those together, and you're not covering everything. You're not covering all the other things. You're not covering the increased risk to the mother, to you name it. I must say, I'm with Michael Auerbach. How can you not screen? Again, the point is made, women are disadvantaged inappropriately because people are fixated on hemoglobins that they don't know about all the other benefits of iron. Sure, I must say this has been the most active echo meeting we've ever had. There are so many questions here, and we're already 7 minutes over time, so we have to stop now. I think we will have to have this session again at some place, but there are many complimentary comments in the comment section. I'm so sorry we couldn't get to all the questions. Really wonderful talk. Please, Evan, keep on giving this talk. And I really think it was super informative. It seems like everybody appreciated, which tells us how important this is. Thank you, everybody, for your comments. Sorry we couldn't answer all the questions, but a lot of food for thought. And again, a good reason for all of us to become experts on iron, because it is such a common problem and we can make such a big difference, which you've shown us very clearly. And I think we all know a little bit more today on how to manage it. So all the best to everyone. Thanks again. I want to say thank you again to the team behind the scenes who are supporting us. Thanks to the Echo PBM or the Gastro Echo team, the team in New Mexico. Thanks to Cheryl Valentine for all your support and inputs. We really appreciate it. Recordings will be available on the Gastro Foundation website, so you can have a look again. We thank Gastro Foundation, Professor Chris Kassianidis, who apologized that he couldn't be here, and our sponsors as well. Next week will be lower endoscopy. And above all, thank you, Evan. You really made our day. Have a lovely afternoon, evening, and morning for those of you from other parts of the world. Bye-bye, everyone.